I'm going to kick us off by welcoming you all to this concurrent session, Improved Data Collection and Centralized Reporting for Veteran Dental Care. I hope everyone had a good break, and we appreciate your patience and some of our timing with our lounges, but it looked like people were engaged in some conversations, which is super. I'm going to turn this over to Eric Tranby from CareQuest Institute for Oral Health, and he's going to introduce our speaker for this session. Eric?
Thanks, Grace. As Grace said, my name is Eric Tranby. I'm the Director of Analytics and Data Insights at CareQuest Institute. It's my pleasure today to introduce this talk on improving data collection and centralizing reporting for veterans dental care. As we know, and as was covered in the introduction to this seminar, veterans often face a complex array of concerns, coverages, and comorbidities that need more coordinated care than most people. Modern EHR systems offer the possibility of that connection, but are often not designed to work together and seamlessly share information, with particular challenges transmitting information from the dental side to the medical side and vice versa. Moreover, these systems are often not designed to give patients direct access to their data, even though we know that patients want to receive it. Coordinated care and ensuring interoperability is central to our mission here at CareQuest Institute for Oral Health, where we strive to create more accessible, equitable, and integrated oral health systems that serves the needs of our veterans and our broader society. With that, I'm happy to turn the presentation to introduce Rebecca Fien today, where her talk will focus on the problems, solutions, and how we can all participate in addressing and correcting the system. Rebecca Fien, MSPA, is the Manager of Care Coordination Interoperability for the CareQuest Institute for Oral Health. Her work is focused on the design and development of technology and data protocols which support value-based care and interprofessional care initiatives. Rebecca has a background in quality improvement, community health, policy, and safety net dental clinics. With that, Rebecca, we're very much looking forward to your talk.
Thank you so much, Eric, for that introduction. And hello, everyone. I'm so happy to be with you guys today. I'm going to go ahead and jump right into my slides. And I hope by the end of the session, you'll be able to recognize the value of care coordination and the role of interoperability in oral health care delivery, identify recent developments in oral health information exchange, and be able to explore opportunities for participating in health information technology supported care coordination. Just a quick note, if you have a mobile device or a laptop nearby, please keep that handy. We do have some interactive polling that we'll have throughout the session. As many of you know, veterans receive healthcare through an array of potential access points, care delivery systems, and financial structures. In terms of oral health, access and the provision of dental care can be even more challenging with different sources of information and without clear pathways for communication and limited metrics which focus on veterans specifically. This complex system of care delivery and reporting prevents us from having a comprehensive understanding of veteran or oral health. When you add in geographic barriers such as rural communities with limited care providers or poor broadband, many veterans find themselves dealing with a healthcare system that is overly complicated, disparate, and challenging to navigate. The healthcare industry is often quick to focus on person-centered care, where patients actively are able to participate in their own treatment in close cooperation with healthcare professionals. However, as we implement these models, we often overlook the health information ecosystem when discussing how to achieve interprofessional value-based care. Unfortunately, for many people, the focus on person-centered care can often mean that the individual is actually the hub of information and coordination, and they're not given the resources and support for navigating the environment. For many veterans, there's an immediate need to ensure that systems connect and exchange data to improve operations, health information management, and to remove barriers to health. Before I go into further details about data collection and exchange, I'd like to spend a few minutes orienting ourselves around care coordination, because fundamentally, as much as we talk about the importance of data and reporting, it's what we do with that information that is the true value. And through care coordination, we can address systemic barriers that are pervasive in veteran health. Care coordination involves deliberately organizing patient care activities, sharing information among all participants concerned in a patient's care, making sure patients' needs and preferences are known ahead of time and that they're communicated to the right people. And that information is used to provide safe, appropriate, and effective care to the patient. By addressing and actively participating in care coordination activities, we can ensure that we are building systems that are personalized and equitable, integrated, value-based, and that engage the community. I also want to point out that when we speak about care coordination and integration, often the focus is placed on referrals. While a referral might be an essential part of care coordination as a whole digs deeper and occurs when providers collaborate to improve patient outcomes. This means that providers have the right information at the point of care and are able to engage in bidirectional or multi-directional flow of patient information. This allows providers to collaborate, share on metrics, and on incentives. A recent survey of dental providers found that almost 70% of providers could recall an instance where access to medical or dental information would have improved patient care. This is why improving health through care coordination is so vital. The provision of care in many dental settings is shifting towards a holistic approach, which is patient-centered and includes assessment of social indicators of health and the collaboration between care providers and community support systems. We know that having access to real-time electronic health data can improve patient safety. It enables enhanced care experiences where the patient is actually part of the care team and allows providers to understand health risk factors. Additionally, the use of aggregate health data can help identify specific community or population-based needs to help build community partnerships which improve health and lead to economic benefits. Despite our efforts, dentistry is still seen as outside of the core health delivery team. A 2021 survey of care providers and staff found that dentists are rarely or never considered part of the care team. We have to ask ourselves why, with all of the evidence we have towards the impact of oral health on the systemic health and all the opportunities we've had to work in partnership with medical teams, why is there still a disconnect between healthcare teams and dentistry? I'd like to have you guys engage in this and your responses. So you can either use your app, your smartphone to scan the QR code or navigate to menti.com and enter this code. We'll also put a link to the participation directly into the chat box. All right, and we'll just wait here and see if we have any answers. So we do have politics and silos. And I'm going to talk more about the silos here in the next section of this presentation. History. That would be an interesting topic to learn a little bit more about and what you meant by that. Another one, the whole system set up to keep dentistry separate. Dental records not integrated, and that is the reason why we are all here today. Challenges in integration, lack of understanding of value. This is all great responses, and it all leads us to sort of the next section of the presentation. Thank you so much for your participation. As you can see from your own responses and a little bit of what I've shared, the role of collaboration within healthcare delivery and what we think some of those barriers are. As we know from some research, both medical and dental care teams are 2.4 times more likely to integrate oral health when health information technology isn't a barrier. So let's talk about how we can address some of those barriers and where those barriers come from. I'm going to start with what exactly is interoperability. Interoperability is the ability of different information systems and devices and applications to access, exchange, integrate, and cooperatively use data in a coordinated manner. Interoperability facilitates the connections and integrations of disparate systems regardless of the origin or destination, and it ensures that data is usable and readily available to share. In summary, interoperability allows us to send, receive, find, and integrate data that we need to deliver the best care possible, and doesn't matter where the origin of that data is. The absence of interoperability among electronic health record systems leads to systemic barriers which prevent a healthcare system that is personalized and equitable, integrated, and value-based. This is especially true for dentistry because of the long-standing separation of dentistry from the rest of the healthcare delivery system. The separation has ingrained silos into the very technology systems that we use to collect, share, and report data. We must address and break down those barriers and silos in order to improve the direct care delivered, ease administrative burdens, and enable collaboration between all actors within the healthcare space. If you remember back to where I described healthcare as an environment of independent, complex, and distributed systems, and how that creates a burden on the individual patient, I think we can visualize it a little bit differently when we think about how it impacts providers, payers, and administrators. So this is the point of care structure for connected technology. It's probably the scenario that most people think about, and certainly what healthcare consumers tend to experience the most. The direct relationship between the provider and the patient in a clinical setting, and all the technology where data may be collected, captured, and reported from. But the healthcare system is much more complex than this, and data exchange is exchanged with many more entities. At this next tier, we have health and administrative data flowing from one clinic to larger systems, perhaps a group practice who is using business insights, for example. In the medical scenario, it's really easy to imagine how this information is shared, such as in a hospital setting where multiple departments have access to centralized patient records. Then we can add another layer, another tier in, where you have health and claims data moving from the provider systems to external systems, such as pharmacies or payer exchange for claims and eligibility verification, or even through a health information exchange. And now, as personal connected devices and health apps become more popular, we have to find a way to take that patient-generated data and put it into, find a pathway into the health information collection and exchange as well. It is hard to imagine a dental health ecosystem which functions at the level of complexity as illustrated in this diagram, especially since it was only in 2019 that the adoption of electronic health records in dentistry went past the halfway mark. Meanwhile, at the same time, 96% of hospitals and 86% of physicians' offices had already implemented them. We also have to acknowledge that there's a significant difference in what is reflected in the diagram, considering the differences in practice size, resources, and the challenges that providers in rural areas who may not have hospital systems or large provider networks to rely on as a backbone for information exchange. According to the VA, nearly 24% of veterans live in rural areas where consistent access to care can be challenging. And in this ecosystem, as complex as it is, we have yet to successfully solve for families and individuals who frequently move or receive care while outside their home area. This is often the case for military and veteran families. But the technology in the healthcare ecosystem isn't just about clinical data or administrative and billing claims data. We are actually still part of a larger learning system that dentistry isn't able to take a full advantage of. This diagram illustrates that learning system. An ideal interoperable health IT ecosystem should support clinical public health functions, including real-time case reporting and disease surveillance. Additionally, through interoperability, this system can support data aggregation for research, and it can lead to improved clinical guidelines and practices. Over time, interoperability will support the combining of administrative and clinical data to enhance transparency and enable value-based payment. Unfortunately, for dentistry, the system is working exactly as it was designed, which means that the data that many dental professionals collect is left out of this learning system because we rely on electronic health records that are incompatible with each other and the larger health system. We must advance oral health information technology and ensure that it is the connective tissue needed to make meaningful impact and drive change within our industry. I'd like to take a moment and think about the practical application of this. Marcy, our veteran here that I've been using in our pictures, in addition to having to coordinate a variety of care delivery systems and insurance groups, also has chronic kidney disease, which complicates her health and requires significant coordination of services and care plans. Recently, we convened a focus group of medical and dental providers to discuss a variety of chronic illnesses and the type of information that should be exchanged to ensure timely and appropriate care. On your screen is a short list of information about a patient with chronic kidney disease from that group. These items were identified as being helpful to dentists during treatment, so at the point of care. I'd like you all to take a moment and respond to the poll that I'm going to pull up on the next page. I'm going to ask you, how confident are you, based on the list, which I'll pull back up, that you could access these pieces of information at the point of care in a dental office? Go ahead and use your smartphone to scan the QR code, or to open the poll, go to venti.com and enter the code that you see on the screen. We'll also put a link to the poll in the chat. I'm going to go ahead and give you a few minutes to respond to each of these categories, and then I'll pull up the results. I'd really like you to think about the information listed here and under these categories: diet and lifestyle, lab results, conditions, treatments, medications, and interventions. Which of these things are you able to access without a significant amount of administrative burden and pre-planning? All right, at this time, you should be able to see the live results. As you can see out of our audience here, for the most part, there's very little to no confidence that this information would be available at the point of care while you're treating a patient. To me, that's unacceptable, and what brings us here today. We should have the right information about the whole person at the point of care so we can make appropriate care decisions and collaborate on treatment plans. Thank you for your participation. Thinking about where we are today and the siloed systems that we have been operating in, and the case that we just talked about with chronic kidney disease or any other chronic disease, how would you rate the dental industry's ability to participate in information exchange? For providers and clinical teams, how difficult is it to send, receive, find, and integrate essential health information into our clinical systems? How much administrative effort does it take to request and manage information? Is there even a place to store some of this information within our electronic dental records? How does a whole person view of data relate to the information that we use to report on quality and health outcomes? On your screen is a summary of the US CDI, which is a standardized set of health data classes and constituent data elements that have been identified by a large group of stakeholders and published by the National Office, the Office of the National Coordinator for Health Information Technology. These data elements are essential for transitions of care, for clinical information reconciliation, to update and share medications, allergies, problems, to be able to transmit to a third party, or even for third party access by the patient through a portal or an application. These are essential data elements that we need to deliver care. But it's important to note that dental is not represented here at all. And there may be a few cases where an ICD-10 code or some other code set may identify a condition that represents an oral health issue, but there's still significant barriers for dentistry to participate in most of the categories of data listed here. And that's partly due to how we collect data, limiting to CDT codes and not capturing diagnoses, and relying largely on dental technology, which is built separate from medicine. We must take steps to overcome these barriers if we're going to improve the way we share data and participate in whole person care. I want to take a deeper dive into one of these challenges, coding and terminologies. Since dentistry relies on CDT primarily, with a little bit of increasing use in ICD-10 codes to capture disease, it's helpful when working in a collaborative interprofessional environment to use a cross-coded or mapped table such as this value set, which is actually for reason for a dental referral. These can help make sure that all parties involved can communicate successfully. But even within these tables themselves, we know that there are small issues that could lead to larger data problems. Take, for example, some of these concepts such as dry mouth and the codes related. In here, I think it's reasonable to expect that most providers, medical or dental, would be able to read whichever of these codes and understand from the description what the condition is, and then use that to plan treatment or coordinate on treatment. However, there are codes where our best attempt to match and align don't work, such as lack of recent dental care, where here SNOMED and SNODENT are relatively similar, while the ICD-10 equivalent, patient's noncompliance with medical treatment, could mean a whole host of different things, and certainly wouldn't necessarily indicate that they didn't attend a dentist in the last 12 to 18 months. Simple inconsistencies such as these may not seem significant, but as we think about how we begin to look at veteran health data and how we collect information about disease, conditions, and behaviors, and how those get reported, this is very important to consider. While I've brought up a lot of barriers and challenges in communicating about health and data sharing, it's not that they're not going addressed. Recent development for and use of data exchange standards, for example, will help us move the industry along so that we can collaborate. The CDA and FHIR dental data exchange guides were recently published by Health Level 7, or HL7, as you may have heard of. A group of national partners and thought leaders, including representatives from the Department of Defense, the American Dental Association, and the Federal Electronic Health Record Modernization Program Office, as well as our team at CareQuest Institute for Oral Health, collaborated on these guides, which include critical information for electronic dental health information, coordination, and exchange. These standards provide a framework for the sharing of electronic health information between software applications, with the overarching goal of making sure that the right people get the right information at the right time to provide the best care possible. Specifically, these guides define the standard referral and consult documents needed for bidirectional exchange between medical and dental providers, or even between dental providers. It's important to note that the participation of the Federal Electronic Health Record Modernization Office, or FIRM office, which works within the federal space to implement a single common electronic health record that enhances patient care and provider effectiveness. This is really important for veterans, as the work of this office will help ensure that patient information can be shared within the federal space, as well as externally for contracted services and for transition to private sector providers. Utilization of these standards can extremely improve our ability to communicate and collect data on veteran health. Unfortunately, these standards and others such as electronic eligibility verification are dependent on implementation and utilization, as they are not mandated for use, or at least not yet. Providers, healthcare systems, and payers need to advocate for the adoption and inclusion of standards such as these in future technology systems or updates to current systems. So even though we know that care coordination and the exchange of essential health information is important, it often seems like barriers are insurmountable. And a provider may be thinking, I want to know what I can do in practice today to address veteran oral health. And there's a few things that we can talk about that gets us closer to bringing us to our goals of personalized, equitable, integrated, value-based care, and shift that burden away from the individual. I want everyone to remember that we have health information as a tool, but it's only one part of a supportive system, and it shouldn't be used or even discussed as the solution to our problems. Rather, it's something that can be utilized to support improving health outcomes. And today we can address practice culture, knowledge, and skills and processes in an environment that offers financial incentives and assistance for transformation, knowing that as we do so, technology will continue to develop and become available. For example, some of the technology that's already available are patient portals, which are secure online websites or applications that give patients access to their health information. Recent federal regulations have placed an emphasis on providing patients with access to their health information through electronic means. Portals often have a variety of features such as appointment scheduling, educational resources, and provider messaging. Additionally, it provides access to health history, lab tests, imaging results, costs, billing, claims, and much, much more. These features are designed to help patients stay informed and better engage with their personal health. A new survey from the CareQuest Institute for Oral Health recently captured patient perspectives regarding portals, both medical and dental. As you can see, 7 out of 10 of the respondents wanted their patient portal to contain both medical and dental records, and adults wanted their dental records shared with their medical teams electronically. Also, we can say that from the responses that a majority of the respondents thought that access to their health information, their dental health information, would improve their ability to track and understand their oral health, increases their trust in their provider, would increase the likelihood of scheduling and keeping appointments, as well as increasing their engagement with their dental health. From these responses, we can confidently say that patients see value in this type of electronic health engagement, and that dental providers have opportunities to engage with their patients through electronic communication and information sharing. While implementation of a new patient technology might be burdensome and costly, the activation of a patient through engagement with portals may provide a significant return on that investment. Another opportunity is participation in health information exchanges. These entities intend to provide solutions to support information exchange, interoperability, while maintaining privacy and security requirements. They also help coordinate Medicaid and state public health programs, provide monitoring and tracking of metrics and outcome data, and are partners in establishing strategies to meet gaps in communication. Approximately 92% of the United States population is currently served by a health information exchange. We also know that several state HIEs have dental participants utilizing emergency dental department notifications, prescription drug monitoring programs, the exchange of medication, allergy, and condition information, and several states are also working on establishing plans to incorporate specific dental and oral health conditions into state-based HIE capabilities. I would strongly encourage any provider or network to reach out to their local HIE and see how they can start participating now. because as you participate now and maybe be able to look up some of the medical information in there, we'll be building relationships that will help us when we're able to contribute dental health information as well. I also want to challenge you to think differently about information that you are collecting and how you're engaging with the person in the chair, rather than just seeing them as a patient in the chair. We know that healthcare is only 10% of what influences health and well-being. We must consider the conditions in which people are born, grow, live, work, and age, their social determinants of health. Do most providers even know if the person in their chair is a veteran? That's the first step we need to start identifying. How would knowing that a veteran might, that the person in your chair is a veteran, how might that change how their treatment is planned and delivered? Think about what you hear during this event, and then ask yourselves how you can do better to identify the challenges and barriers that patients face every day, and then how you can be proactive in your community to drive health improvement. There are a lot of resources on how to assess and address social determinants of health. We don't have time today to go into those models, but I do encourage you to look at what's available and find a model that might fit your needs. It's so important to collect and report on the social determinants of health data because it defines and documents the complexity of patients. It helps providers and communities target enabling services. It demonstrates the value that providers, especially dental health providers, bring to their community, and it will help in value-based payment design. Social determinants of health data is essential for advocating for change within the community and at national levels. So in summary, I want to just reiterate that healthcare data empowers healthcare teams, it informs public policy, and it changes behavior. To improve oral health outcomes, we have to improve the way we collect, share, and use healthcare data. Integrated and interoperable oral health information technology is the connective tissue to get us there and to achieve those better health outcomes. Dental providers, payers, and technology vendors must be held to the same standard of data collection and interoperability as the rest of the healthcare system. And through the adoption of dental data exchange standards, new technology solutions, payers and providers and their patients will have unparalleled access to digital oral health information, supporting better health outcomes, enabling value-based payment opportunities, and really will shepherd in a new era of disease surveillance and care coordination for veterans. And I just wanted to say thank you. And here's my contact information if anybody would like to reach out to me. And then I think we have a little bit of time if we have any questions.
Yes, thanks so much, Rebecca. That was a really awesome presentation. We have a lot to consider and think about for how we improve veteran health through coordinating care and the data exchange piece that you touched on. We had one comment in the chat so far from Wilhelm. Do we want to go to just participant view, gallery view? If you stop sharing, and I don't know, Wilhelm, if you'd like to share that with the group. And if others have questions, you can either put them in the chat or take yourself off mute.
Well, I actually go by the name Bill. It makes it easier. Okay.
Hi, Bill.
Hi. Just a couple observations, and that is, there are programs already that are out there, but I was very concerned because when I was one of the deans at the University of Michigan, we developed a program called Victors for Veterans and also Wolverine Patriot program. And those programs communicated with CBOCs and volunteer dentists. And yes, we did have challenges in disseminating information from one platform to another because of the lack of communication with EHR systems. However, we recently, now that I'm at UCLA, we're going ahead with a program called Brew and Stars and Stripes, where we now have an IT platform that is cloud-based. We share radiographs, pertinent information, and we do demographics on each person, understanding all ICD-10 codes, both medical, dental, followed by the CDT codes. And I have to tell you that the most disconcerting thing that I've come across is the lack of understanding by champions in the dental community of the available programs to veterans. And one being specifically the MetLife program that was underwritten by Delta Dental and MetLife. It's called the VA DIP programs, Veterans Dental Insurance Plan. And that was basically available to all veterans. And we were trying to figure out how to underwrite the premiums and copays because all veterans qualify for this plan. And it was very reasonably priced as well. And I believe that program is coming to an end. And if somebody could tell me that it's going to be extended, that would be helpful. So I'm just sharing with you that platforms do exist. And I look at how do we enhance the efforts of champions in the communities. And I will tell you that I am involved with a program where I contend that health professionals at all levels are the most underutilized asset in schools that could be part of this program. And we have demonstrated that value over and over again. And quite frankly, the data that you suggest is not inexpensive. I have to pay $1,500 per clinic and $120 per user. And that's the student. That gets to be a pretty hefty information. However, it has simplified the outcome for veterans enormously. With that, I'm willing to answer any questions if anybody has any. But so programs do exist and communication does exist, okay?
I absolutely appreciate that feedback. And I definitely agree with you. There's a lot of people working on a lot of different solutions out there. And I think that they are underutilized. There's probably a couple of reasons why. And I would, if you gave me a crystal ball and asked what I kind of see the future around data collection and interoperability for oral health is, just as the medical side has nurse informaticists, I think we're going to see dental informaticists, maybe hygiene informaticists, people who are coming in with a technology background, filling in some roles so that, you know, the dentists who want to be delivering care and treatment can do that while still be participating because they have a team behind them that can support them and get them engaged in some of these interoperability and data sharing platforms. As far as finances go, you know, if you ask me, I think one of the great things that was made available early on for health information technology was meaningful use and the incentivization of the adoption of technology. Unfortunately, that was not designed in such a way that dentists were really able to take advantage of it. I'm not calling for any policy recommendations, but I would encourage anyone who has a role in the policy sphere to consider how we can maybe start thinking about incentivizing participation in the health information technology ecosystem for dentistry and dental and oral health programs.
Thanks, Rebecca. I'm going to wrap us up just so we have time for folks to transition to the next set of concurrent sessions. But I think you can find Rebecca and Eric in the Hubelo platform if you want to continue any conversations or ask other questions. CEU, please jot this down. Here's your code for this session to get CEUs. It's DATA 215 VET. So that's data 215 VET. And your choices for the next two concurrent sessions: advancing medical dental integration for veterans or expanding the role of rural health clinics in veteran oral health care delivery. So navigate back to Hubelo, join the session at the session start time. I know sometimes it's hard to make a choice, and we are recording these sessions and we'll make sure we have them available through the platform after the event. So hope that helps a little bit. Thanks again, Rebecca and Eric, and we will see you soon.